some of y'all's faces look scrunched up. Yes, okay. Dr. McNeil gave you a lecture over this. It's just an introduction. Professor Fetters gave you 3 separate lectures. It's actually one big lecture. Abnormal, normal versus abnormal chest x-rays. I had a student email me something I actually told them wrong because we sat the other day and kind of talked about this. And again, as you know, this is like a new way for us doing this, so we're always going to find things where we're like, yeah, how are we going to fix that? How's that going to... Someone was concerned about the fact in Nikki's lectures, she went over medical conditions that you have not been given yet, like pneumonia. Okay. I actually really sat there and thought about it, because I told the student, don't worry about it, put that on your back burner. Whenever pneumonia comes up, then you can, okay, that's not really right. Because Nikki brought up a great point. You're not getting another radiology lecture. You've not been given all the radiology you're going to get. This is it. You're not going to get a second lecture in that second block. So, it's not focusing on the medical condition aspect of, like, let's say pneumonia, or let's say pneumothorax. Those are like the 2 biggies people always love to use in phys die, because everything else is pretty boring. You hear crackles, bronchi, blah, blah, blah. Pneumonia is the biggie, pneumothorax is the biggie, because you can do a lot of funky things on physical diagnosis to diagnose those, and a radiology for that matter. You obviously have not had those 2 medical conditions, right? But I'm not going to test you over pneumonia. I'm not going to test you over pneumothorax. You're going to need to know the physical diagnoses, how to diagnose those with hyperresonance, dullness to percussion. Those are the phys di things you're going to need to know. Does that make sense at all? Because the person that emailed me, I do not want to steer you wrong and be like, and now you've completely put that off. You need to approach radiology in that same manner. It's not going to give you a case vignette and say, patient's coughing, blah, 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 here's a chest x-ray, what type of pneumonia is this? That's not what it's going to say. It's going to say something like, if you had an x-ray and there was a complete whiteout of the lobe, and they had fever in this, what's a possibility? Well, pneumonia, it's a consolidated whiteout, you see that. Does that make sense? So I feel like I'm really not driving that home. Yes?
So will we ever be given an x-ray without any information, just to, I don't know, would the question be identify what is this x-ray without any patient information?
There's no way you could do that.
Okay.
You cannot do
There's
that.
a massive, I don't know.
You couldn't do that in medical practice.
Okay.
That's just not realistic. No.
So there would be always.
Absolutely,
Okay.
you gotta know that, yeah. That'd be like looking at a crystal ball. Yes, you will have to know a case vignette with an x-ray. No, just, what is this? Unless it was ortho. Ortho, you probably could get by with that. Like, what's broken in this right here? Radius or not normal. A good question. So again, radiology, don't freak out and get caught up in trying to memorize pneumonia, pneumothorax. This goes for phys di and radiology for that matter. Don't get caught up in that medical condition. Get caught up in, if I have a person walking in, what are some steps to doing a physical diagnosis? What do? I inspect, I palpate, I auscultate. That's what you need to start wrapping your head around that. Because I get it. I thought really hard about what that student said. I was like, yeah, I can get how that'd be really stressful because you've already gotten your radiology for this section. You're not getting it again for pneumonia, pneumo, and all the other stuff that's going to come up. But again, that's where you have to write very fair, broad test questions. So radiology, internal radiology, Dr. McNeil, the basics of that, and then again, Professor Fetters gave you 3 lectures. Pharm, Dr. Latassi's done the asthma, infectious disease, and when I say infectious disease, I mean bronchitis, bronchiolitis, that type of stuff, which is really basic stuff. Asthma is going to be your one that you're like, oh my God, because it is overwhelming. It is, I know. And then Dr. McNeil did an intro to antibiotics. Yes.
In that lecture, he told us that was not going to be tested.
Yeah, I know he did.
So it is.
But here's the thing, you already kinda should know, I mean, don't panic. And to be real honest with you, he's not submitting any questions from that lecture. There's no questions that have been given me from that lecture yet.
It would just be, that would probably help us with like the farm infectious.
I would say, yeah, absolutely would help you with it. Did Dr. Latassi go over any antibiotics with you?
That's the last test block. Few for this one, just which will correlate with the others.
Okay. Don't forget about the intro to antibiotics, okay? Just hang that there. It's a great lecture though.
We liked it, we all thought it was really helpful.
I wish you would have given it to us earlier.
Yeah, I
Oh,
think
at the beginning of it?
Yeah, because
That's
it's
a
like-
great suggestion. We can
Yeah.
possibly move that maybe somewhere else.
Move that into,
ENT.
yes, the very first
Yeah.
lecture.
Yeah.
Because you're right, you shouldn't be looking at his lecture and going, because I would hope you covered macrolides, penicillins in ENT, correct?
Plus, the thing
Well,
is,
we
haven't
were
covered
not.
any, but
She
we
just
were
assumed we
expected
knew
to
them
know
already.
what did what, and so like, now we're finally learning what we've been like memorizing.
Yeah.
Yeah.
And
like
so
we're
it's
learning
just
it.
late.
She never sat down and told us what each thing was, is the point.
we didn't even know what classes were.
Yeah, we didn't know. She didn't tell us any of that.
So give that lecture
Okay, look back there. It's
First
okay,
day.
this is a learning, it's cool, we're cool, we can learn together here on this. Let me write that down, that's a great idea.
Maybe like the intro to farm course.
Yeah.
In ENT.
Yeah, because
There's really not many antibiotics that, there's not very many right now.
Not at all.
Like, we could spend a lot of time.
Well, because thus far, you will get it pneumonia. Thus far, you haven't, for mine anyway, you haven't had any conditions that really take antibiotics yet. Besides acute bronchitis, which a lot of people argue you don't even need antibiotics for that, actually, but we give them. And the number one thing we give is azithromycin. But you technically haven't had any great antibiotic stuff yet here, because you haven't had anything. Asthma, yeah, if they have a secondary bacterial infection, you can throw something in there. But pneumonia is where your antibiotics, because obviously that is a legit infectious process, right? You have to treat that. You're going to get your macrolides, your pins, all that good stuff. And TB, you're going to have antibiotics in that all day. That's a big. But I think that's a great suggestion regarding the intro to farm, and I
Yeah.
will definitely tell them that needs to be plugged in. That's a great idea. Okay. Don't freak out about the Dr. McNeil thing. Let me take a look at that, okay? And I'll get back to you guys today. Just chillax on that. I can see it in your faces. Okay, so again, phys di, we kind of already talked about that, right? Professor Fetters gave you a lecture over that. And again, look at it from a broad approach. Don't go start looking at direct medical conditions that she may have mentioned in there. You need to understand the steps to a systemic, how you would do a physical, I don't know what I'm drawing for here, a system-approached physical exam on a patient. If you walked up to them and they came in with a cough, they came in with shortness of breath, how would you do that physical exam on that chest? What would you do? What are the steps?
Inspect, palpate, percuss.
Very good, very good. You need to know that stuff. You need to know what a history is. She talked about history with you guys. A patient comes in, they sit down, they say, man, I've been coughing for 6 weeks. It's dry, it's worse at night. Delsa makes it better, running makes it worse. What is that called? What did I just tell you? That's exactly right. That's a history of present illness. But if I said, so have you had any fever? Have you had any weight loss? No. Yes, I've had weight loss. Have you had any night sweats? No. And I went through 50 months. What is that called? Review systems. Yeah. Try to go like that. Try to do it that way. I'm not telling you there's not going to be questions on there that says you listen to a patient or you percuss and there's hyperresonance or there's dullness here or there's rat crackles here, you're gonna need to be able to, but that again is not a medical condition that you're needing to focus on. You're needing to focus on the physical diagnosis aspect of doing a good lung exam. Does that make you feel better about that? Kinda? If not, ask me. Physiology. Now, there is a definitive place where she stopped, right? You guys are cool with that, you know that? Okay, so then go from where she stopped and go forward. Learn forward. Pull out your objectives. Answer the objectives that she's had you, given you thus far with your lecture. If you can do that, you will do fine on her test questions. Because I broke hers up to try to spread it out where she's not like firing at you in 2-hour block, a whole freaking lung physiology lecture. So do you have her objectives? Has anybody ever pulled those out and just tried to answer them?
Yeah, she like covers every little detail.
Yeah, she does.
It's like 4 pages.
There's like, yeah, way, yeah, it's a lot.
Objectives as a handout?
Yeah.
She,
Yeah,
her,
put it
her
It's
handed out.
on D2L.
Yeah,
It's
it's,
more helpful
Or
than some of
outline?
the slides.
Just
Is that
literally
all-
everything.
I just feel like you can use the slides.
And you could look at the slides, you could do that.
it is, because she just like asks like 3 questions per slide.
I like
Okay.
to see that stuff.
That's really what it was. I mean, yeah, they're good objectives, but they're just,
It's a lot.
instead of like broad, like, you know.
I mean, I'll do
no-
it later.
Physiology's not broad.
Yeah.
It's just not. Physiology is in depth. So lab med, Dr. McNeil gave your ethics lecture. Did that rock your world? Okay, good. Okay, good, good. That will be on your test. And he writes his own test questions.
CBDs will be on the test.
So from the clinical medicine aspect, which is what I love clinic ed, love it. Myself, Inowitz, Scott, and then Kincaid have given you your clinics thus far. That's all you have for clinic med. So cystic fibrosis, pertussis, RSV, bronchiectasis, acute bronchitis, bronchiolitis, croup, ARDS, influenza, and vent use. Guys, that is not bad. That is not bad. That's like so freaking doable. And what I'm telling you, if you can pull out the 5 objectives, because it's the same stinking objectives for all of those. Pathophys, signs and symptoms. How do you work them up? What diagnostic tests, if any? How do you treat them? Do y'all know those? They're the back of your syllabus, and they're the same for all clinical medicine, medical conditions. If you can answer those 5 things, general pathophys of those, general first-line treatments, which there's not a whole lot in this section because it's kind of viral stuff. How they present. If there's a special test that just jumps out there to diagnose something, RSV, it's a swab, that would be a question. You got this. That's not hard stuff. It's really not. Breaking it up into 2 tests is going to be better for you. Yes.
Asthma is on there as well, correct?
I'm sorry, I did forget Mrs. McCrae. Yes, I'm sorry.
Just making sure.
Asthma is on you. Yes, ma'am. Yes, ma'am.
So for ARDS and ventilation, you say like it follows the same thing, but
Vent use doesn't.
but yeah, his stuff yesterday was just very, very in-depth and didn't really follow the, like, it's as if you're gonna use like the pearls to guide you.
You won't just get pearls. You should not be just memorizing pearls.
Well, I get that. I'm just saying his was very, very like molecular in-depth.
Okay?
I don't know.
Right, I understand what you're
That's
saying.
all
Well, because
it
ours,
follows.
acute respiratory syndrome is not acute bronchitis. That's a pretty intense, I mean, that's like intensive ICU internal medicine, right? That's intense topic. I'm trying to get in there. But there would never be a question over a molecular, you know, it would be like, what's the most common cause of ARDS?
Okay.
What is the most common cause? What's one of the most common causes of it? Sepsis. Sepsis is a biggie that causes people to have acute respiratory distress syndrome,
Organ failure? Isn't that one?
which is secondary to, yeah, everything
yeah.
just starts to shut down in sepsis. I swear, after you do this, after you do poem, you do cards, you will, I said this to you guys the other day, it's true. You will be able to start picking out what people are gonna ask you. You won't be so caught up in like little bitty, like, I gotta memorize this. It's not gonna be like that, because it's not like that in real life. I mean, a patient doesn't come in and tell you the most in-depth things of something. They tell you the generalized stuff about what's going on with them. Now, ours is an audit, it's an oddity, because it's different. People are very, very, very ill with that. I was trying to pull it up real quick and just kind of look through it. And also, he lectures nationally on acute respiratory distress syndrome and vent use. Like, that's his baby, which is why I asked him to come. So lectures that will not be in this blog. I know a couple of you guys have emailed me and then I sent out a massing bill. I'm just gonna kind of try to read. TB will not be on this exam. TB will not be on this exam. Both the clinical medical and med aspect of it from Dr. Harvey or Dr. Latassi's pharma lecture on TB. Dr. Munoz pathophysiology will not be on this exam. That was him. He didn't want to pronounce it. Does everybody understand that? Okay. So some just random stuff. I've already said a lot of this. I don't want to bore you. Please study all components of radiology and phys val. Again, I told the student, don't worry about pneumonia, blah, blah, blah. That's kind of true. I don't want you to get caught up in the clinical medical aspect of it. I want you to take it from a radiology aspect. How do you read an x-ray? How do you approach an x-ray? What do you look at first? What do you look at second? What do you look at third? Always remember to look at lecture objectives. I can't stress that enough. I understand physiology is kind of tough, because it's a hard one. It's a lot of information. And if you found a way to study her lectures versus doing objectives, then God bless, go for it. I understand if you say you just open the slides up and do it that way. But you'd have to use your slides to answer your lecture objectives. Study most common first line treatment stuff. Do not go and memorize the third, fourth thing that you would throw at an asthmatic if they first line, most common, and you'll see that like in some of your slides. First line treatment is, most common treatment is, no, I'm not just saying that for asthma, I'm saying that for other stuff, like pertussis. There's other things you can use for pertussis, but what is the first line, what do you use first? That's right. Very good. Also, gold standard. You'll see that a lot in lectures and stuff. People have like, the gold standard test for this is a VQ scan or a CT scan or a lateral check, whatever. If it's a pneumothorax, it's an expiratory film. If it says gold standard, then you need to memorize that. Please. So we'll do some review questions. Any questions so far? Y'all feel any bit better? I know, are y'all, maybe y'all aren't, maybe y'all like, man, this is pretty cool. It's broken into 2 blocks. I can focus on this.
No.
Focus on that. I promise you can do
I
this.
honestly just wish that the TV and phys ed stuff, like I know we have one radiology lecture,
Yes,
but while we study everything, if that could collaborate with the second part of the exam, that would be so helpful for us because we can correlate what we're studying in faculty with phys ed.
yes. And whenever that comes around, you can pick that lecture back up and when you do it, look at it under phys ed and radiology that correlates with the TV and the other stuff. Any other questions so far? Concerns? A great suggestion on the ENT, the intro to antibiotics, I would totally pitch that one. That's doable, that's so doable. Yes, ma'am?
Typically, everybody else has said 7 to 10 questions per 2-hour lecture. Is that kind of the guideline that you're following?
Sure.
And you said that the radiology is pretty much mushed into one, so is it 7 to 10 questions, or
Or
are
is
we
it-
like,
It's considered
15.
one lecture,
okay,
All radiology?
not dance,
So like, okay.
not dance.
There's 7 questions for all 3 of those.
Betters had 3.
No, I think she's saying, are you saying Fedex is 1 lecture, all 3 of them, so 7
Yes.
questions are all 3 of them?
Right, hers is technically a lecture, one lecture. It's given as one lecture, broken up, it's big.
Because if we miss one,
But then there's like,
Okay.
to turn it on.
Okay, so let's do some study questions. These are just kind of examples of what will be on your test. I'm not saying these are exact questions, but this is how you kind of need to approach this. So what I like to do, because sometimes the clicker thing takes forever, and you have to look at the poll and all that jazz. If you want to take out a sheet of paper, you can just like silently take your test, like, write it down, see if you know the answer. And then, of course, we'll go over why it is what it is. So these are just general questions, kind of like what you will experience tomorrow morning. I can never will just top it away. Did you not read that? You do not have to write this down. That's not what this is about. This is for you to read the question, use your brain, and sit here and say, okay, I want to see if I can answer this test question. All right, if I did, I'd send you this lecture for you to sit here and write it down the whole time. I wouldn't worry about that. I want you to read this question, think. Use your brain right now. Okay, so he's already on albuterol, right? What do you think you should do now? There you go. Very good. You wouldn't switch him to a LABA, a long-acting beta-ag, would you? No. So what is he? If you had to think about, like, what would you classify this kiddo as? He's 12. Where would you classify him? Is he controlled? He's not controlled, right? And there's telltale signs there. He's having to use this inhaler, a crud load during the day. He's waking up at night from a nocturnal cough, and you're gonna see this. This is a classic case. This is like, I see this all day, every day when I was at Family Medicine Clinic. Kids would come in, How's your kid's asthma? Oh, they're doing great. They use their albuterol inhaler every day. You know that your kid is not doing great. But this is why I give you, because this is legit. This is what you're going to see. So you sit there and you go through their meds and you go, wow, he's only using albuterol. First and foremost, is he using his albuterol right? Tell me how he's using it. Well, he does this and that, make sure they're using it right. You'd be shocked. People don't even actually how to use the thing sometimes. Then you have to kind of determine where are they at. Are they moderate? Are they severe? Where are they at? Well, the kid's not even on an inhaled corticosteroids. Don't go jump to a LABA or jump to a, just do what's next in line. You're going to add an inhaled steroid to the patient's albuterol. Because what is his albuterol considered? You need to know this when you educate moms, dads. Well, but we like to use, I use a different word for it instead of short-acting albuterol, yeah. It's a rescue. That is the rescue inhaler. Because people, I would say 80% of the population that I dealt with at family medicine thought that sucker was like that was their asthma med, was their albuterol. That is a rescue inhaler, meaning you're freaking over there dying, you should be using that, not using that every day. Because people don't understand that. That's considered a rescue. So what is an ICS? Inhaled corticosteroid. And by the way, if you see an acronym in any of your lecture, and it's a biggie, and you need to know what that means. Because I don't want to get on a test and be like, we didn't know what ICS stood for. You need to know what that is. That's an inhaled corticosteroid. What's that called?
Maintenance?
Maintenance, controller, those are the words you're going to use. And this is not testable stuff, guys. I'm just trying to teach you something here. That's your control. Or maintenance, love that. Because these are the words you're going to use with mom and dad, grandma and grandpa. Rescues albuterol, salmeterol, there's a gazillion different inhaled corticosteroids out there. Flovent's a biggie. We use Flovent a lot because it's covered on center care, it's covered. You can't just go and prescribe them. Because those meds, those inhaled corticosteroids, if anybody in here has ever had to use them or buy them for your family kiddos, they are astronomically expensive, like $250 for one thing. Yeah, so and you'll learn as you practice what you can and can't prescribe because it's not covered. Flovent's a biggie we give folks. Salmeterol, you've seen the commercials for the Brie, but there's tons of them out there, different ones for those. A lot of times if you feel like they're on the albuterol, they're not doing so well on the inhaled corticosteroid, then you can do a combo. Lots of people love combos. That's the inhaled corticosteroid plus a LABA. I always say LABA-SABA, it's an easier way to say it. So an inhaled corticosteroid plus a LABA. That's your combo that we like to give a lot. But this is how you kind of need to start thinking about this. Don't get cray-cray with theophylline and cromolyn. I mean, don't go there. It's not going to be on your test. It's going to be this stuff. And if they mentioned an inhaled corticosteroid you by name, you need to know that. Not 25 different inhaled corticosteroids by name, but one that's common, first line that she may have talked to you about. Is everybody cool with that question? Yes.
Where does the bronchitis come into play?
Oh, okay, good, very good. Because as an asthmatic, that's actually just kind of throw you off there a little bit to think, ooh, something else is going on. But they're actually, you're going to get that a lot as well. You'll have asthmatics that are, the biggest one, it should say allergies on there. That would be a great question. Asthmatics that are not controlled, but they're not controlled because something else is going on that's making them, allergies is the biggest one I see kids come in with, and they're using their albuterol like 5 times a day, but they're not on anything to control their allergies. They're not on a Claritin, they're not on a Singulair, they're not on a Flonase. So if you control that aspect, then that won't flare up as much. This case, the kiddo was just that
So if
sick.
they say allergies, then you would treat the allergies.
Yeah, absolutely. Now, you will get a lot of times where kiddos come in with asthma and they do have like an acute illness that's superimposed on their chronic, and you will have to identify both of them. And in this case, which the biggie there for you that you go, this kid's not controlled, is one, 2 to 4 times a day, 2 months, nocturnal cough, he's only on albuterol. No, he's gotta be on something else. The bronchitis was just, that's why she was bringing it in. Yes, ma'am.
Okay. I think you kind of answered it, but I think.
No, go
would you-
ahead.
I mean, would you even, like, because it looks like he's not controlled at all.
Yeah,
Yeah, so, I mean,
you would definitely add on.
okay.
If you wanted to treat the bronchitis with some oral steroids, you could totally do, that would be totally legit, by the way. Totally legit. And in fact, if I saw this patient in my clinic, this is what I would do. I would make sure he didn't have an underlying infection, like, you know, has he got pneumonia, has he got something going on? I would not do a chest x-ray in this kiddo, because I am very freaky about x-raying kids. We over x-ray kids in this country big time. I would look at his pulse ox. I would look at his vital signs. Is he tachypnic? Is he tachycardic? Is he having to work to breathe? Is he eating okay? Is he throwing up? Does he have fevers? Signs of a secondary bacterial infection. If I didn't see those there, and the kid was in the room jumping around eating Cheetos and drinking Mountain Dew, and I'm serious, you laugh, but these are things that will make you feel so much better when you walk in a room. Peds scared me to death, by the way. Pediatric patients, I'm always like, God dang, they're dying in there. But then you feel good, because you walk in, the kid's jumping off the damn table, tearing paper up, and you're like, he's okay, he's doing better, he's good. But these, seriously, you ask about food. Food's a huge indicator for kids, if they're sick or not. Yeah, he's not eating or drinking. That scares me a little bit. But if they're in there eating, drinking, doing fine, no fevers, vitals are huge too. I've told you that. I read an amazing article. My husband and I went to this emergency medicine thing last year, that there was an entire lecture over vital signs that is so often overlooked in the emergency room. People just walk in the room and start talking to the patient. I'm like, did you even look at their freaking blood pressure that's 101/55? That's not good. I mean, so look at the kids. The kid's vitals. If the kid's vitals were rocking, he was 98%, he was not tachypnic or tachycardic, I would not do an antibiotic in this kiddo. I would give him, honestly, an oral steroid. I'd give him a 5-day course of prednisone. 5-day course. You can do 3 or 5-day course. I don't know what exactly, Tiffany. I know they feel a little bit more comfortable giving longer courses of steroids. But in primary care family medicine, we're getting a little concerned with giving out steroids, because, you know, giving steroids, there's side effects of that as well. So I'd give this kid a 5-day course of steroids, 20 milligrams of prednisone times 5 days. Get his albuterol, make sure he knows what he's doing with that, make sure he has refills on it. And then I would add on an inhaled corticosteroid. And I'd bring him back in 3 to 4 weeks and see how he was doing on that. If I thought he had an infection, I'd give him azithromycin if he didn't have an allergy to it. Azithromycin's excellent lung coverage, right? Excellent lung coverage. Azithromycin. I'd put him on azithromycin, put him on an oral steroid, make sure he has his albuterol, add on an inhaled corticosteroid, bring him back. Bring him back. Make sure he's doing good on that. Go over his asthma action plan with him as well. That's huge. So that's a great example of your chest right there. We already kind of answered this one. Two. So give me some examples. What's the biggest one that we see? Albuterol. Albuterol. That's the one you're going to deal in all day, every day in your practice. Unless obviously you go into Pulm or something down the line. But albuterol. It comes in a nebulizer, comes in a handheld. Believe it or not, you can actually take albuterol in a pill form. I learned that last year. I saw a patient in family medicine and I was like, I didn't even know that. One of the docs had put them on it. I was like, yeah, that's, There's different types of short-acting beta agonists. Did she talk to you about levobutyl? There's a different type of albuterol that we give to kiddos that's not as, doesn't cause as much tachycardia. Because if you've ever seen a kid or had a kid do albuterol, especially nebulizers, it's like my pet peeve. They would be bouncing off the sticky wall. It like jacks them up. So if you have a kid that you're already concerned about their little heart rate, you don't have to give them albuterol, you can give them the other one to help with tachycardia. Just FYI. I've never given number 3. I'm not saying it's a bad drug or anything, I've never dealt in that one. I've definitely dealt in 1, 2, and 4 all day, every day with my patients at Family Medicine. And the more you deal in those when you get out, I promise you they will not be so scary, as is everything right now. Okay, this is your Fizz Die hat. So last sentence, what is the most likely diagnosis given in the physical exam findings? I don't give a crap about what he's COPD. Don't care about that.
2.
There you go. She's like, yeah! God dang, I can do this. But do you see what I'm saying about the whole panicking about pneumonia and COPD and pneumothoraxes and all that jazz? It's, don't take a rocket science. If something is highly tympanic, you're going back through that lecture and you're reading these buzzwords that you hear when you auscultate someone's chest or you percuss someone's chest. Highly tympanic means there's nothing there. If it's dual to percussion, what's there probably? Something's there, yeah, because something's there that should not be there. But that's how you kind of have to think about your radiology and your physical diagnosis lectures. You can't auscultate breath sounds. Why is that? Because there's not a freaking lung there. I'm serious though, okay? So does that make you feel a little bit more comfortable about that in your Fizz Die? But go through that Fizz Die lecture and think about sounds. What it sounds like when you percuss. What is tactile fremitus? What is whispered pelvic blah blah blah? What are your special tests? $99, yeah, A's, E's, all those, I know. Pectiliquid, I can't even say it. Say
I don't even know the word either. I don't know.
Pectiliquid.
I don't know.
Hate it, it's embarrassing. I feel like an idiot. It should say test. Which of the following test is best used? Sorry, I typed this like at midnight. I was tired last night, my babies. Totally PFT. PFT, pulmonary function test. That's all we do at pulmonary function tests with somebody. Tiffany went over spirometry with you from PFTs. She brought, that's intense, I know, all those FEV over, FEV1 over FEC, it is intense, I know. I asked her to really just kind of do that again, given the physiology thing. Pulmonary function tests, absolutely. You get those numbers back, they spit them out to you. And they tell you percentages, 75%, 60%, 85%. And you can look at those numbers and automatically start piecing them together and go, this is obstructive. No, this is restrictive. Don't worry, there won't be other than asthma, there will not be like some long case scenario that you have to put numbers together and figure. It's not going to be like that. But then once you get into obstructive, you have to think, what is obstructive? What are my obstructive lung illnesses? And then there are numbers that come out of that PFT that even break it down further that you can pull out from your differential well, this number's this, so it can't be emphysema. They took a shot of albuterol and it improved. It's not COPD, because COPD doesn't improve with albuterol. What improves with albuterol? Asthma. 12%, 10, 12% of it improves, 10, 12%. Arterial blood gas, ABGs, arterial blood gases, sorry. Those are excellent tests, but it's not what you would do to determine a restrictive versus obstructive. Can you imagine getting an ABG on a kid? You ever had an ABG? They take it, you can actually do it venous now, it is normally arterial. They do it from the arterial side, but you can actually do a venous ABG. They do it, my husband does it in the ER, they don't, because arterial hurts more, it's painful. But ABGs are excellent, but it does not tell you restrictive versus obstructive. It can tell you if a COPD or an asthmatic, because what do they tend, when they're really in respiratory distress, what do you think they hold on more to? CO2, so it's going to make them more. Very good, yes, very good. Ventilation perfusion scanning, if you'll remember, I actually asked a question to Robin about VQ scanning regarding pulmonary embolism. VQ scanning is where they make them inhale, and they also do an isotope via the blood, and they match it up in the lungs versus bloodstream to see what's not matching up. Pulmonary embolism, if you hear VQ scan, PE should go off in your head. Ding, 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 like that's the test it's not the gold standard, because if you have a patient that comes in and they're crashing in the ER because they have a PE, you're not going to order a VQ scan on them, because they're not going to make it. What's first line for PE? Does anybody know? I shouldn't be you on that. You don't know that yet. It's a CT scan. CT scan is an excellent test for a PE. Yes, ma'am.
Her lecture specifically says it is the gold standard for pulmonary embolism
Okay.
on slide. But is it just either or kind
Well,
of
I
thing?
guess if you want to take it from an emergent versus a non-emergent, you're not going to have too many people walk into your clinic, like my family medicine clinic, and go, you have a PE, I'm going to order a VQ scan on you. 9 times out of 10, when you have some, it is because it is the gold standard because it is most specific and most sensitive to a PE. But you're going to order a CT scan on somebody that has a PE, because most people that present with a PE, it's going to be emergent. It's like a VQ scan takes, just like an MRI, that's why they don't do MRIs in the ER. They do sometimes, but CT is like the go-to in the ER. Because it's quick, fast, I can get you in there, get you out, and know the results. It probably actually is considered, it's probably more specific and sensitive. That's not a lot there on that. She's not wrong on that. You just don't order a VQ scan. Chest x-ray? No. Pulmonary function test. And I know you guys just got this lecture yesterday, so you're probably not in deep in it yet, so. So ARDS,
It's one.
yeah. Not a lot of congestive heart failure associated with ARDS. Sepsis is like one of the #1 causes for ARDS, which is the organ failure, somebody said that. That's what basically, there's different types of sepsis. You'll get our shocks, you'll get into that later on. But basically, when someone has full body sepsis, things just start shutting down. Kidneys, heart, lungs, all of it. Decreased lung compliance, because obviously it's just starting to fill up, they just start to fill up, so they can't perfuse, they can't ventilate like they're supposed to. And then that is like the classic, like pathognomonic on your board, I hate that. It's a complete whiteout. I don't know if Kevin, I haven't even said that to you. It just looks like cotton, like a fuzzy white cotton all over their lungs. So, look at that 16, number 16, sorry. looks like this on X-ray. You could have lungs. There's like a cavitary. That's white. Air fluid, that's what we, if you don't know that, you should know that also from ENT. Air fluid level means air fluid, and you can see it differentiated there. Not good, not supposed to be in the lungs. So what does that radiological finding suggest?
Fluid effusion.
I'll tell you about pleural effusion in a minute. It's an abscess. An abscess. An abscess is where the person was sick, and it just kept getting sicker, didn't resolve, and it formed, basically like if you ever had an abscess on your skin where it's full of pus and junk, and you gotta drain it, that happened in his lung.
So when you say air fluid line, how do we differentiate that from pleural effusion? 'Cause doesn't air fluid line mean effusion? That's what we're
Okay, so pulmonary edema and pleural effusion are actually two different things as well. Pleural effusion is where there's actually like liquid in the, like in the actual cavity, the lungs. Not a loculation or actually, this is inside your lungs. Like if you had your lungs and you have an abscess in the lungs, as where with like pleural effusion, which there's different, you got a PA or AP, whatever, you got a PA, AP, and you have a lateral. A lateral is really awesome for pleural effusions because when they go to lay on their, if they lay on their side, or it's called a lateral decubitus actually. Did Nikki talk to you about that?
Yeah.
When they go to lay down, fluid moves, right? So it's all gonna move outside. You can see it when they go to lay down. Now this would move also, if you tilted it like this, but it's gonna be in the actual parenchyma. It's actually in the lung tissue. Pleural effusions are not in the actual lung tissue. Also, there's a really awesome telltale sign that you can look at on a chest x-ray, like a AP or a PA, whatever. AP actually is the one we get. It's called the costophrenic angles. Does anybody remember that from your lecture?
Mm-hmm.
That's like the first thing I look at if I think somebody has like fluid out in their lungs. And this is a horrible drawing, I'm sorry, but you have your costophrenic angles, they kind of look like this. If there's fluid there, they are just blunted. You cannot see them. They're gone. If you has anybody over here looked at, well, obviously you probably looked at Nikki's. When you look at the costophrenic angles, they are like these very sharp, defined pieces there. If there's fluid, you can see it. They're not there. It's white. It's blunted. And that's what the radiologist will actually say. They'll say blunting of the costophrenic angles, suggestive of fluid. So abscesses are in the lung parenchyma. TB is in the lung parenchyma. Oh, I just spit a word, I'm sorry. Pneumonia is in the lung tissue, inside it. Pleural effusion is outside the lungs in the cavity. Pulmonary edema is a little different. Pulmonary edema is actually in the lung parenchyma, but it's not actually in the alveoli. It's like in the tissue that surrounds it. People get pulmonary edema. It's tricky. Did you do pleural effusion? Did Nikki talk to you about pleural effusions?
Yeah.
Can you go back to the question?
Yeah.
that's what I was gonna ask you.
Oh, it says pleural space.
Yeah.
That's all, yeah.
But I mean, that's still the lungs. I just say lung parenchyma. Okay. I actually took this from a PANS board book.
So if there was nothing mentioned about a bacteria, you could assume that it's pretty much, it could be an infusion. But given the extra strep pneumonia, you start feeling abscess. Because the way it's worded, that could go with the pleural effusion.
Yes.
It could.
Is it the leukocytosis that says abscess, maybe?
You can have abscess, but it's not as, you can have an abscess anywhere in the body, actually. But it's more in the lung parenchyma usually, like in the tissue,
Yeah.
in one of the lobes. It's not in the cavity. Okay, I'll give you that one. Maybe that's not the greatest question.
But now we know the difference.
What did it say that?
So now we know the difference.
How do I explain that?
Are you happy, guys?
Yeah, I remember.
It's the inevitable, so.
I see what you're saying. I'll totally agree with you on that.
I would have guessed,
Say that again? You would have guessed what?
I don't know.
Okay, sorry, I thought you were trying
No,
to
it's
say.
fine.
Okay, we can, if it didn't have this case scenario up there, where you knew he was sick, and it just didn't get better, and now he's obviously got a raging infection because of vitals, labs, and physical, his telling you stuff.
Would you expect to see leukocytosis in any of the other options besides
Right,
abscess?
like that. Abscess,
And TB?
yes. TB possibly, if it's a cavitary lesion, and I know you don't know what that is yet, so don't freak. But TB sometimes can like eat away and get really funky in the lung tissue and cause an infection. Pleural effusion, not so much, but what did I tell you about anytime there's fluid sitting in a stagnant area that should not be there?
That'll lead to another
It can lead to
infection.
infection, but that's a good question. 3 and 4, not so much. Not if they just had, let's say in some alternate universe, they just had a pleural effusion. People come in with pleural effusions all the time, not all the time. Congestive heart failure patients are really bad about having pleural, because the fluid overloaded. Not so much on 3 and 4. That's a great question. TB, yeah, abscess, abso-frequently, you have an abscess in your lungs, so you're gonna have an elevator blood cell count. Sorry about that question. That's not the greatest question in the world. Here's just a little, I don't know if this will make you feel better. So I took this from a Pants Review book, board question book. When you take your boards, I did not know this until afterwards, you have like, I'm making this number up, you have like 300 plus questions or something on your boards, right? Okay. There's only like 100, 150 of those that are like the legit questions. The other ones are what they call beta questions, where they see, if is this a good question? I don't know, because you can't always write a good test question. I hate to tell you, it happens. You write bad test questions. So they'll throw in these beta questions, and if people do really poorly on them, they know, hey, I'm not going to use, we won't use that again for the beta pants. Isn't that kind of cool? I didn't know that until after I took it. I was like, only 100 of those counted? It's not just 100. I don't know the exact number. I'm making that up. Which actually, I'm going to tell you something about our next review, what you're going to do, how we're going to do it. We're going to do something different, something fun. So you'll learn how hard it is to write test questions. Okay. Oh, come on, don't be like that. No, this is amazing. This is like the only time in your life you're ever going to get to have this experience. Seriously, that's the way you got to look at this. This is it. You're learning. Embrace it.
We're laughing because we thought the question was up.
These are some of your words. So I'll go, just, and somebody yell out, if you want me to go back, I'll go back. Yes, 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 yes. x-ray, like, I don't know.
I guess too.
All right.
Okay, so first and foremost, he's dropped a lung again. You're dealing with a pneumothorax, and I understand you're not,
Yeah.
because your x-ray shows a visceral clot, just not, so basically he's dropped it, he has low side chest pain. It's not there. His lung's gone. So again, kind of like on your percussion, if you don't have a lung, what's it gonna sound like? It's hyperresonance to percussion. It's like a drum. That's the way I always remembered it. Like you're a beat on a drum, you know, how it makes that drum, like that hollow sound. That's what hyperresonance sounds like. It's kind of the there's like actual lung tissue there. Oh, do you want to take a break? What?
It's like, so, this is the,